Good morning, everybody out there from a cold and cloudy and windy Johannesburg. I think this is autumn. It feels like midwinter. But thank you for joining Daily Maverick and Maverick Insiders this morning for a discussion on the COVID-19 epidemic and the health and medical response to the COVID-19 epidemic. We are, I believe, 13 days into a 21-day lockdown. That's 62% of the way through the lockdown. The end is in sight, although whether the end is indeed in sight is something that we'll discuss with our guest. Our guest is Professor Salim Abdool Karim. Professor Abdool Karim, I'll call him Slim because we're friends as well. Is a very renowned scientist, South African scientist, with decades of experience in the HIV epidemic. He's currently the chairperson of the Ministerial Advisory Committee on COVID-19. So I think we're very privileged to have somebody who is deep on the inside of the thinking about this crisis that besets our country. But I will say at the outset that Slim is not a government official. So a lot of this discussion today is going to have to revolve around the health response, what we understand about COVID-19, questions of treatments, questions of vaccines, etc., etc. I think we'll have to leave the social and economic questions, which of course are very, very important questions, to another discussion and to another day. So, Professor Abdool Karim, welcome. It's great to have you here. I want to start just by asking you to take us back a little bit and to explain to those who are watching and listening today what the lockdown aims to achieve. What are we trying to do with this from the perspective of stopping the transmission of this virus? Can you just start at the beginning, if you like, to help us into this discussion?
Sure, happy to do so, Mark. So I think we have to take one step back first, and that is recognize that we did not know that this virus existed prior to December 19th of last year. So when the first case was reported from China, was the first time we even knew that this existed. So our entire experience of this virus is less than 4 months in total. But what it means is because this is a completely new virus, it's a virus we've never encountered in the world before. It means every one of us is at risk. No matter what your color, whether you're white, black, brown, doesn't matter. Doesn't matter whether you're man or you're woman, you're old, you're young, you're rich, you're poor. It's irrelevant. The entire world is at risk, every one of us, because we've never encountered this virus before. We have no protection against it. We have no natural immunity against it. We have no vaccine against it. So we are all at risk. So that's the first starting point. The second is that because this virus cannot move on its own, it has no ability, innate ability to move. If you put it here, it is here. That's it. It has no ability to move, which means that it moves because we move. We are, as humans, are the main way in which this virus moves. So fundamentally, our behavior and the way we interact with our fellow human beings determines how this virus moves. So we cannot blame the virus in any way for the way it moves. We are the reason that the virus moves in the way it does. So we knew that this was coming. And the reason is very simple. We are a highly globalized world. We have people moving all the time. whether it's from Europe to Africa, whether it's from China to Europe to China to Africa, it doesn't matter. We have, this whole world is so interconnected that in this kind of setting, a virus that can be transmitted through the respiratory route was always going to be a challenge. Now, this is not new, and this problem is not new. This virus is new, but this problem is not new. The reason this problem is not new is that the WHO and all of our organizations have always been scared that we will have a pandemic flu. All our planning has been based on pandemic flu. And I should know, I chaired our government's National Advisory Group on Immunization, where we talked about pandemic flu preparedness. What does it take to prepare for it? I can tell you, nothing of what we discussed, nothing of what we prepared got us ready for this situation. And so because you have a problem that all of us are at risk, because of our human interaction, we spread it one to the other. We have seen what occurred in Italy. So I'll use Italy because it's a very clear example. So in Italy, once the virus entered into the community, so the first wave you expect is the wave of people who bring it through travel. So they go to an infected area, they come back and they bring the virus, and they are the first ones to get disease. So they are the first cases. You expect that in every situation other than China. So in China, of course, you know, the original epidemic came from the seafood market, right? And it's thought that the pangolins contributed to it, but that's a separate discussion. But you know that your first epidemic is going to be among travelers. The second wave that you expect are the contacts of the travelers. So that's the people they interact with at work, at home. And so you would expect that that's the next wave. You expect also to see nosocomial spread. In other words, as these people go into hospitals, because hospitals have, you know, all the conditions for this virus to spread. For example, this virus survives for a very long time, right? 5, 6, 7 days on stainless steel.
Nosocomial for our listeners, watchers, means hospital acquired through lack of systems of infection control in hospitals. Continue, yeah.
And because hospitals have, if I'm going into too much detail, just say so. I'll be more succinct.
No, but it's an important background. I want you to get to the lockdown before too long, but this is an important foundation.
Sure. So because hospitals have this kind of situation where they have large amounts of stainless steel, they create the hard surfaces on which this virus survives for quite a while. So they're an important way in which the virus can spread. So you got the second wave, which is contacts of the travelers and nosocomial contacts of the patients. And then that becomes the bridge into widespread community transmission. And when that happens, and we look at Italy, you have this exponential growth. Because the reproductive rate of infection, which means how many people will one infected person infect? So if one person has the infection, how many will they spread it to? In influenza, it's only one. Well, not only one, but it spreads 1 to 1. In this particular virus, it spreads between 2 and 3 people. So up to 3 people will be infected from each person. So if you have 10,000 travelers who are infected, you can expect they will infect within a matter of 2 to 3 days, they will infect 30,000 people. Those 30,000 within a few days infect 90,000. And it just grows exponentially in that way if you allow interaction to be unfettered. So we had to stop that. And that's what the lockdown is about. The lockdown is about reducing the human interaction that facilitates the spread of this virus from one person to the next. So we cannot, if we are infected, any person is infected is not interacting with enough people to cause 2 to 3 people to get infected. That at most they infect no one or one other person. So we call that, you know, reducing the reproductive rate, but net effect is you flatten the curve. So that's what this is about. Sorry, long explanation, but I hope it explains.
Long, but necessary explanation. And let's just stay with some of the basics. So we know it's an infectious virus. We know it's a virus that's never been seen before. We know how important human interactions are. I want to talk now about the disease quickly that the virus causes, because obviously we're most scared about this disease and its ability to kill a lot of people, cause a lot of illness, and to overwhelm our healthcare systems. And my understanding is that, you know, we have a particular vulnerability, or we think we have a particular vulnerability in South Africa because we have high levels of pre-existing diseases that will predispose people, you think, to illness, such as HIV, such as diabetes, hypertension. So whereas developed countries, the big risk is primarily, and you'll obviously refine what I'm suggesting to older people. In our country, it's older people plus. So there's a particular urgency to trying to stop this thing, because it could, if it behaves in the same way as it's behaved in Italy or China or America, cause devastation on a far greater scale. Can you just talk a little bit about the science on that, and then we'll come back to lockdown again. But let's get the foundations laid for this discussion.
You've captured it, superbly. I'll just expand on it. So when you see this exponential growth, in other words, when you see the number of cases increasing very rapidly, what happens is that the number of people who are sick and need substantial medical care rapidly rises. So we know from the analysis of about 45,000 patients in China that about 81% of patients get a very mild disease, a disease that they can just deal with minimal medical intervention. We even know that a small proportion are even totally asymptomatic. So we know that this is the case, but it's that 19% that need medical care that's at issue. And 5% require very significant care, including ventilation. So when you have a situation where you need ventilation, you need ICU care, the number of ICU beds and ventilators is very small. You can't really have major supplies of that. So each hospital has a small number of those beds. But when you have this exponential growth and you have thousands of people that constitute that 5% that need very significant medical attention, the healthcare system just gets overwhelmed. And that's what you saw in New York. Basically, there's patients everywhere, outside on the street, in the corridors, everywhere, and they need ventilation. And you don't have ventilators. And so they just start dying. So you look at last night, the announcement in New York that over 2,000 deaths from a city that has 8 medical schools, several hospitals, sophisticated medical care, not enough ventilators. So that's the problem that occurs. In HIV patients, we do not yet know how this virus and this infection is going to play out. When we had a conference call with our colleagues in China, we had all of the leading experts in China advise our Ministerial Advisory Committee last week on Friday. We asked them the question, can you give us some clues as to how this virus, what was the disease progression in patients with HIV? Well, they had a total of all those 76,000 patients, they had 1 patient who had HIV. And that patient was on antiretrovirals and was virally suppressed, and he had an uneventful course. So that's the sum total of what we know from our Chinese experience. The Italians will give us better clues, and the US will give us better clues. But we are the ones that are going to have to deal with it. I would, if I was asked to speculate, and I'm making it very clear, it's not based on evidence, speculation. I think we're going to find that patients who have HIV, who are virally suppressed, will be impacted at a slightly worse level of disease progression than patients who are HIV negative. So I'm not overly concerned about that group, but I am deeply concerned about those who are HIV positive, who have viral loads that indicate they are immunocompromised. I'm expecting that those young people are going to have a disease course that's more in line with the aged people that we saw in China. So we're going to see a much more severe disease. This is only speculation, not based on evidence, but that's what I think may happen.
Plausible scientifically. And just to quantify what that risk represents, there's about 2 million people, I believe, still in our country who have HIV, are not yet virally suppressed, i.e. they're not on antiretroviral medicines. So it's a large number of people who could be at risk. And so this is why, you know, people in health, well, it's not just health, talk about the precautionary principle. There's a very grave danger. You can't exactly quantify it, but if it's as bad as it could be, you have to do everything. You have to throw everything at it to try and stop it. And with HIV, because I keep on thinking about, you know, we've had 3 million deaths due to HIV in 20 years, but HIV never had this direct impact on our health system in the way that a far smaller number of people is going to have an impact on our public and private healthcare system. And I guess the way I understand that from what you're saying is that COVID-19 concertinas everything into a very short period of time, and it hits in one big wave, whereas HIV was the long period, asymptomatic period. Then people got TB, they got a variety of other conditions, but you didn't get this big all at one time hit. Is that right?
You've captured it, and I can quantify it for you. So in HIV, from the day you get infected to the day you have clinical illness is on average about 7 years. With COVID, it's 7 days. So what in HIV took us 7 years to see the impact at medical care, in COVID, we see it within a week. And that's the concertina timeframes that we're dealing with. It should be pointed out that when you are looking at a problem like COVID, and you're looking at the people that we have that are at highest risk, we estimate somewhere between 2 and 2.5 million people in South Africa have HIV infection and are not on antiretrovirals. And if we work roughly on the basis that about 1 out of 5 will have immunocompromised state, in other words, a CD4 count below 200 or 350, then we can say that it's that 500,000 people that are really the group we need to be concerned about. We don't yet know how it's going to impact on them, but if I was going to be concerned, I would be concerned. Those are young people, and they are walking around in our communities, they're at risk, and if they get it, they may have a very severe course.
Yeah, so this is potentially an HIV emergency as well as many other types of emergency. And it's something that civil society organizations like the Treatment Action Campaign need to be taking very, very seriously. Salim, I think we've laid a foundation. I now want to go back a little bit to how we're responding in South Africa and take advantage of your position and your knowledge. So we locked down on the 26th of March. I don't know the exact numbers then. The numbers 2 days ago or yesterday were 1,749 confirmed infections. I guess you're getting information all of the time. I mean, you're in the nerve center of this. 2 weeks into it, what's your initial impressions on whether this lockdown is, let's be very tentative, showing signs of possibly flattening the curve?
Yeah, so it's difficult to tell. And the reason it's difficult to tell is because when you look at cases, you have to appreciate that when we say that there was a case today, that represents an infection that occurred about 2 weeks earlier. Because of the incubation period, 7 to 10 days before you're sick, then you go to a doctor or you go to a clinic, then they see you, and then they take a swab, then the laboratory does a test. So by the time we have your actual result is about somewhere between, 12 to 15, 16 days. So I'll just take 14 as a rough number. So if we base it on that, the cases we see today reflect infections that occurred on average about 14 days ago. So the infections we see now are infections that occurred prior to the lockdown. So we can't really tell based on the cases presenting with illness. So we've chosen to go a different route in this country. In every other country, when you look at this epidemic, the way in which they dealt with it is that it came upon them so rapidly that before they knew it, the epidemic showed itself in the long queues of patients coming to the hospital. So the virus, in the way it interacted with society, was through large numbers of patients coming into the health service. South Africa went a different route. We said, we are not going to wait for that. Instead, we are going to go into the community and we are going to go and look for where this virus is before people come to the hospitals, before they need that medical care. We're going to be proactive. We're going to try and get ahead of this virus, and we want to see how it is spreading within our communities. We're not going to wait till they get to hospital. That's too late. That the boat's already gone then. So we need to get into the communities early. And so you heard the President announce that we will have community health workers going house to house to house. And so when we look at that, latest estimates, I think, was just over 28,000 community healthcare workers are going house to house, screening people for symptoms. And if they have symptoms of this disease, they're being referred to the clinic where a test is taken. And so looking at the numbers, we can now tell, are we seeing community transmission or not? Because if you were to ask me, can you tell me that we're winning this battle? My answer is, I don't know. I don't know if this virus is spreading in the community. I'll tell you in 2 weeks' time when they pitch up for medical care. But I can't tell you now because I don't have the information. And I really worry that the conditions in this country make it difficult for large sections of our community to institute hand washing on a regular basis, to institute social distancing. So the two key tools, the two main tools we have, hand washing and social distancing, are hard for large parts of our community. So if this is spreading, we better get to know it. And so the President took the most proactive position we could ever have. And no other country has done this. We've chosen to go a route early with the lockdown, early with our interventions, and we've chosen to now go and find the virus in the community. Now, once we start seeing it, we can now institute our interventions. Because in a way, it's a bit like we're seeing little sparks. If we see it in the community, we can go in and dampen it. Instead of having like an Australian bushfire, where it's just going everywhere and we have no way of stopping it. It's just beyond us. So we want to try and tackle it in that way. Can we identify where it's spreading in the communities and try and halt it at that level?
So that's very interesting what you've just said, and it leads to two questions that I think a lot of people will be asking. I know a lot of people are asking. The first question is, you say we can only really tell in 2 weeks. This 1,749 tells us something, but it doesn't tell us most of the things that we want to know. Does that mean that April the 16th, we're not going to be in a position to lift the lockdown because we won't have enough information? And I would imagine that it would be the most stupid thing to do, to lock people up for 3 weeks, get the beginnings of a benefit, and then open the chicken hatch before we're ready to do that. President Ramaphosa yesterday said, you'll decide in the next few days. And I would imagine that you're one of the people who will be giving input. That's one thing. And I'll just flag the other thing, but I want you to take that first thing, is the question of testing we're going to have to talk about, because there are issues about between the policy and the intention and the actual implementation and capacity to implement what you have just described, which is effective community tracing through significantly scaled up testing. But let's put testing aside for a few minutes and talk about lockdown, another 7 days or another 7 plus 21, or what's the thinking? I know you can't tell us, but how will you measure? How will you make that decision?
So fortunately, I'm not the one that makes any of those decisions or in any ways involved. I just simply provide the best advice that I can. If I wanted to know whether we are in a position to end the lockdown, it really revolves around how well do we understand community transmission. And if we see from the community health workers that are already in the field that we are receiving enough specimens and we're testing them and we're not seeing positive cases that are substantial, that is very reassuring. It means the net effect is our lockdown has had the desired effect of preventing the virus from spreading from person to person. If we see that it's localized, that there are a few communities where it's spreading, then we can make a decision as to whether we want to ease the restrictions in certain places and not in others, or what do we want to do that may be a sort of partial decision. But I think at the end, if we find that we're not really seeing community transmission and that we have the wherewithal to continue very carefully our ongoing surveillance with lots and lots of testing, so that if we see something, we can deal with it, then lifting the lockdown makes a lot of sense, because then we are creating the conditions for, we're saying we have the conditions where the virus is not spreading and we can release it. If we release it and we go back to our old ways of hugging and kissing and shaking hands, we're going to go back to square one. We're going to be where we were some 1 month ago. So we're going to have to change many of our behaviors even beyond the lockdown. And I think if we can do that, I think we have good grounds to intervene in that way. There's also many models that have looked at what options we have. Some models say actually the best thing to do is to release the lockdown for a week or two and then reimpose it. And that sort of approach is being promoted in many instances. Others have said, and China is a classic example. Remember, we learned about the lockdown from China. They were the first to institute it. Their approach in Wuhan was to just go for one really long lockdown. And so I think they're on day 76 or 77 in their lockdown. So that's almost 3 months, right? 2.5 months. And of course, they just released the lockdown now. The travel restrictions in Wuhan were released yesterday. So they are convinced they've got no local transmission. And the way they know that is they've tested. And they now know they have no restrictions. So there's no need to maintain the lockdown in Wuhan. In fact, China is now the first setting, and Wuhan is one of the first settings that shows that you can actually get to a stage where you have no local transmission. Now you've got to worry about the cycle starting again. So now you've got to worry about people traveling and then bringing the virus back into the situation, and then it spreads again. So you can't, there's no letting up here.
So we've heard talk of a possible second wave, and that's one of the things that China and South Korea and so on are trying to guard against. Whatever we do on April the 16th will be a week closer to winter. And as I said, it's already cold in Johannesburg. Is winter, do you think winter's a factor? Is winter a risk for us in South Africa that you will have to take into consideration?
Totally. I mean, I can't tell you how deeply concerning it is that we are going to go into a flu season. We are very soon going to have two epidemics that could be working side by side, where we will have influenza virus spreading at the same time as COVID. So we are in that sort of difficult situation. We hope that the actions we've taken will have quite a dampening effect on the flu epidemic. So we won't see flu in the same kind of way that we see it every year. I mean, we are used to flu in this country. December, all the doctors know that they're going to see patients with flu. It's just something we've gotten used to. We try and get the elderly vaccinated, our healthcare workers vaccinated, but we are used to that. Now we are going to see those cases, and at the same time, we're going to see patients with COVID, and you can't distinguish the two very easily clinically because they both present with an upper respiratory tract infection. Flu is a bit more severe, so the symptoms are more severe, but you can't really distinguish them. So we're busy looking at how we can do that. So the laboratories are busy looking at a way in which, when we do a PCR looking for COVID, we can also make a determination as to whether the patient has influenza. So we can separate out the two problems. And that's part and parcel of what we are busy preparing for in the winter.
Just to explain, you keep that point, Salim, but PCR stands for polymerase chain reactor test. It's a test that looks for the virus itself, and it's different from tests that look for antibodies. So I just want to make sure people understand that at the moment, what we're doing is we are testing to find the virus, not to the immune response, and that applies to flu. And just also to remind people, how big a threat flu is also in our environment. 11,000 people apparently died last year. That's according to the NICD, just of ordinary flu. But sorry to interrupt you. Finish your point.
No, I think you've hit it on the head. Actually, you reminded me that that's one point that we also will factor into our thinking, and we need to keep it in mind. What proportion of our population has antibodies against this virus? Because that's the protection. And right now, we think, based on the evidence we've seen from China, that when a patient gets COVID, that it seems unlikely that they get it again. So we haven't seen reports of that occurring. So it might be that if you get this disease, you might get reinfected. We don't know that, but you don't seem to get the disease twice. So if that's the case, the number of people who got it and recovered are very important. It also has implications for healthcare workers, that those healthcare workers that have already acquired it, recovered, they are now in a good position to take care of patients with COVID. So there are many implications of that kind of immunity. But right now, we don't have many patients with immunity, we think, because we haven't had much spread of the virus. So the immunity levels will be low. And so that has the additional challenge that we have large populations still at risk of infection.
Okay. So again, I just want to take summarize a little bit of what you said, because it's important. You can recover and you can get infected again. But
we don't know that.
But we don't know that.
Yeah.
But you think that a person who's recovered and gets infected again probably won't get sick again. But again, it's still a new field of science. Okay, that's interesting. It was making me want to ask another question, but I'm deviating a little bit from where I was wanting to take you. I mean,
no problem.
Just to stay with the lockdown, and I don't think we're going to have a chance to discuss it today, but of course the big balancing act is this lockdown is absolutely necessary, and I think everybody who's watching this, and in fact we did a poll, and 93% of people who were asked the question, has government responded well, have said yes. And governments, I think everybody feels that what you're describing is exemplary in many respects. It's the health response, but the lockdown has a social and economic cost. And there has to be a balancing act to make sure that we don't get overwhelmed socially and economically, as well as by a virus, by hunger and starvation and anger and so on. But I'm not going to take you there, Slim, because I feel like that's not really for you. I know you're aware of those issues, but that's probably not the key thing that you're advising the minister and the health department on. I would imagine other people are talking about food and so on. Let's just talk about testing. So we don't, you'll comment on this, we don't test for antibodies. We're not using what are called serological tests yet. We're using molecular tests which are looking for the virus. But do we have a problem with testing? And these, well, I know you're always straight. I mean, I'm surprised we've done 58,000 tests. We've known about this virus since mid-January. 58,000 isn't a lot. And of those tests, 80% are still being done in the private sector. I know we're struggling with the public sector. What's the problem? And when, I mean, we talk about 30,000 tests a day, but we're nowhere near that. Can you tell us what is the issue? What are the challenges with scaling up public sector driven testing?
Sure. I think when we look at the testing we've done in the public sector, given that, you know, roughly 83% of South Africans depend on the public sector, and that we've only done, I don't know, just under 10,000 tests or so in the public sector, that for me, in a population of 55 million, is simply too little. So we actually, that is the point I made, we actually don't know where the epidemic is because we're just not testing. So the challenge was that we were concerned, and people, for good reasons, were concerned that, you know, might not be able to get hold of tests, and when we actually need them, you know, we won't have enough. So let's restrict who gets tested. And so we created a definition that was highly restrictive. It required that you not only have an upper respiratory tract infection, it required that you have traveled or you have contact with a traveler. So it was focused on the first wave, the travelers. It was focused on the second wave, which is the contacts of the travelers and the healthcare workers. It didn't factor in the third wave. And so what happened, we were behind the curve on this one. I have to tell you, everything we've done has been really impressive in how proactive we've been. But the area we fell short, I feel, and I take the blame as much as anyone else, is that we didn't do enough testing because we didn't release the requirements for testing. We didn't ease the criteria for testing. And we didn't ease it for perhaps good reasons. But the net effect is that we are now playing catch up. And that's a very unfortunate situation to be in. We should be doing several thousand tests a day. In fact, if I look at what we need to be doing, we need to be doing in the tens of thousands of tests every day in the public sector. The private sector is a different cup of tea, and the private sector is very important in the first wave. Because remember, I said to you, the first wave, first epidemic is travelers. So many of them have medical aid, and so they go to the private sector. And so the private sector played an important role in identifying those cases. But now we're beyond that. The travelers, we stopped traveling ages ago. So unfortunately, our criteria was stuck in a mode that became a bit outdated. We should have changed our criteria about 2 weeks earlier. But we didn't. We've changed it. Last Friday, we have a new set of criteria that are very much more open-ended, that enable us to really go out there and test people. There's another challenge. It's one thing to say we're going to test thousands a day. It's whether we can get the reagents, whether we can get the test kits. Because remember, the whole world's trying to buy the same kits we are trying to buy. And I don't know if you heard the comments last night from the governor of Michigan. She says, because of the poor response from the national government, they are competing with the other states. So when they want to buy a kit, they say, okay, here's the price, it's this, we'll pay this. New York will outbid them, and California will come and outbid them. So they are fighting amongst themselves for the same goods because those goods are in short supply. What was needed is a national response. A national response that says, let's procure this nationally and provide it in a much more equitable way. Now, the US is an example of everything you can do wrong in dealing with this epidemic. And so we made some mistakes of our own, and we're fixing them as we're going along. We're learning. We're not saying we've made no mistakes, but as we identify them, we fix them. And I think that's the important thing. And I think with the testing, we're hoping that now with the community-based testing, we will increase our numbers substantially.
No, that's very helpful. I mean, because I hear the health minister telling people don't be complacent. I think I'm probably like you, expected the figures to go up much more rapidly from 10 days ago, going up by 70 or 80 a day. Part of you wants to attach some hope to it. And I've heard some people, including senior scientists, say, maybe there's something going on that we don't quite know about. But what you're saying is, and you've said a number of times, it doesn't tell us the story yet. 1,749 doesn't tell us the story. There's no grounds for relaxing our guard in any way. This was an area where we made some errors, forgivable perhaps, but errors nonetheless. Salim, would we be making another mistake if because we can't get the testing kits and the reagents? I mean, I believe there's even a shortage of swabs, which are essential for the molecular tests. Would it be a shortcut and justifiable to switch to serological testing, i.e. antibody testing? I've heard it said that government may be thinking of going down that road. Wouldn't that be a mistake, or is that perhaps warranted because actually there's an admission we can't get the scale we need on the molecular testing?
Yes, so when we look at what our options are for testing, right now, in order to diagnose somebody in acute infection, we need the PCR. We need to look for the virus. And that's the test that tells us whether someone is infectious, whether they have the virus. The problem with COVID, which makes it different from some of our other viruses, is that the antibody response is delayed. So from the time of the onset of symptoms, it takes 5 to 7 days before the antibodies go up. And it takes another few days before they're at high levels. So that means that you have to have a very sensitive serological test, and that you have to be, you will not be able to find a patient in acute infection with the serological test. The serological test is not helpful because the antibodies are not, they're just not present, or they're at very low levels, and so you can't detect them. So you can't take the view that we can take the same HIV approach, that we can just have these rapid serological tests and we can tell who's infected or not, because it doesn't work like that. Also, the PCR test, this test that depends on detecting the genetic components of the virus, that test is only positive for a short period. From the time of the acute onset of the symptoms, for another 14 to 21 days, it's present. Beyond that, it's not present. So that test has a very specific role to play. And principally, its role is to identify acute infection. And so in patients coming in with symptoms, if you want to know if somebody has this disease, no serological test is going to help you. You need PCR. There's a different set of needs that we have. And that is because we know that about 81% of patients will be mild. They won't come into our healthcare service and hospitals easily. And only a fraction of them will actually get to a healthcare service. And so when we are screening those individuals, they will have had the infection and recovered, and we just don't know it. So serological tests are important in that group. There's another approach, which is that if we take patients with mild symptoms, so because when you take a PCR, the actual result, when you take that swab from the patient to the time you get the result, is what we call a turnaround time. And the more tests we do, the longer that turnaround time becomes. So right now, it takes somewhere between 2 and 3 days to get a result. But as you put pressure in the system, it'll start getting out to 4, 5, 6, even a week before you get a result. So we need to prepare for that point. And so for patients with mild symptoms, patients who are in the community with mild, pitching up to clinics and doctors' rooms, they're not sick enough to go to hospital, but they're mild. We want to know whether they have COVID. We have an alternate approach that we are exploring. And that is to do 2 antibody tests 1 week apart, or maybe even 2 weeks apart. So that way, while we're waiting for a PCR result, we can see if the patient has antibodies. And if they were infected and they come back a week later and the antibody test is positive, we'll be able to say whether this person was infected or not. But importantly, we save the PCR tests for those who really need it in the hospitals. So that's part of the strategy. But I wish we had the luxury of time, that we could get these tests and we could assess whether they really work well and so on. So we've taken a slightly different approach. The approach we've taken is that we need to know which are tests that are already being used elsewhere. Those tests we know are rapid tests, and they test for IgM, IgG, so they can tell whether somebody is acutely infected or whether they have the infection long ago. So we use that as a strategy of 2 tests a few days apart, and we implement that while we are assessing it and continuing PCR so that patients continue to get the best diagnostic. Once we know that the rapid tests are performing well enough, we can drop the PCR. If it turns out the rapid tests are not doing well, as has been shown in some countries, then we drop it. We move on. We look for another test. There are more rapid tests becoming available that are PCR-based, that are not serological. So maybe we go in that direction. We have to keep our options open. We cannot have a situation where we want to test thousands a day and we don't have the PCR kits. We've got to have a plan B, we've got to have a plan C, because everything we're doing is so dependent on that.
Thanks, Salim. I'm going to leave testing now. I don't know, some people may have been listening to us and thinking, gosh, this is getting a little bit technical, although I don't see any drop-off on numbers. But I would say that this, for anybody who may be thinking that, is one of the things you and I learned about HIV. You're the scientist, I'm the layperson, is that actually lay people need to understand these questions. And given that testing is going to become such a critical part of our response to COVID-19, it's important that not just Maverick insiders and people who are, in a privileged position to watch a webinar understand the intricacies of testing, but that people living in poor conditions in communities also understand it, because I hear a lot that there's suspicion about testing. When people think they're being tested twice, there's going to be even more suspicion. I was in conversation this morning with somebody from MSF, Médecins Sans Frontières, who says, we're struggling. We need better messages on testing, and perhaps you can take that to the minister, Slim. The messages aren't getting out clearly enough, and they're not getting to the people who most need to understand. People don't just need to be told, they need to be given the knowledge so that they can engage and participate in these health programs from an informed position. Otherwise, this grand task that you've described is not going to work. Now, I'm worried because we're running out of time. We've got about 13 minutes left, and there's a couple of other things, 10 minutes left, that I wanted to ask you, because I think they'll be on people's minds. Just very quickly, everybody's looking for for reasons for hope. And I see circulating widely on WhatsApp and chitter chatter, this and that, hydroxychloroquine. President Trump has, shouldn't dignify with that title, Trump has jumped at that. First of all, is that anything? I saw today a report that the journal that had published it has now retracted it as not being robust enough from a scientific point of view. Second thing, if you can just, and I only give you 2 minutes on each of these, the BCG vaccine. That's another thing that's floating around. Is there some protective effect in countries that have vaccinated people with BCG? We've been vaccinating kids with BCG since 1961, I think, or 1973 as a standard. Any comment on either of those two things? And then perhaps throw in with that, perhaps a few words on vaccine development and exploratory treatment for COVID-19.
Sure. I think I need to start by reiterating what the World Health Organization has said. There is no evidence that any drug is effective against COVID-19, period. So that's the starting point. There is no evidence that any drug, no matter which drug you take, that it works against this disease. We know, and we thought, that lopinavir would be active against COVID. Fortunately, the Chinese did a trial quickly, and so those results were published in the New England Journal of Medicine. It showed lopinavir didn't work. So people were using lopinavir on the understanding maybe it worked. So it's in the same way people are latching on to drugs. So chloroquine, there is no evidence that it works. The 2 studies that have been done, the French study was uncontrolled. So we actually don't know what to make of those results. And it all became a big deal because the French Deputy Minister of Health went around announcing that, oh, France has found a treatment for this. When the evidence it wouldn't even count as evidence in our books. But the Chinese did a study of chloroquine, a small study, 62 patients, and they showed didn't really have much benefit. So right now, we're not sure because the patient selection issues, there were many design issues. Right now, I would say that the jury is out as to whether any drug treatment works against this disease. And the World Health Organization has a large study underway that will test these and tell us whether they work or not. And I think that's what we need. We need some clear evidence before we rush around on this. The study on BCG is a study where the paper is not yet published. It's a preprint. And it was done by the Department of Osteopathic Medicine, I think it was, in the New York Institute of Technology. So in this particular study, what they did is they compared countries that have universal BCG vaccine and countries that don't. So it turns out that, in fact, the US and Europe don't have universal BCG requirements because TB is not a problem there. Africa, where TB is a big problem, we have universal BCG policies. So what they show in this analysis is that the European countries where the epidemic has been hardest, they don't have BCG policies. In Africa, where we have BCG policies, we don't have major COVID epidemics. There's a fundamental flaw. I mean, a grade 1 student will tell you the flaw. Right? You can't make that conclusion because the epidemics haven't hit Africa yet. We are running a few months behind Europe. So you can only make that conclusion when you've seen what the impact of the epidemic is in countries with and without BCG. And very importantly, we need to know in countries where they've had this epidemic, are people who have BCG as affected as people without BCG? We asked that question, and the answer anecdotally is that it didn't matter whether you had BCG or not. So we wait to get evidence for that. Right now, I would say it's an interesting hypothesis, and there are many hypotheses. People, I mean, the number of experts who know how to solve this problem on social media, number in the thousands. Instant experts who have every kind of solution. I mean, I get emails. Why don't you put lemon and and honey in water and take that because it'll kill the virus at the back of your throat. I can go on about the number of people who are instant experts. We can't make policy on that basis. We can't treat patients like that. We have to have evidence. That goes to the importance of South Africa and Africa participating and being in the forefront of treatment studies and vaccine studies. If we don't, if we leave vaccine studies to Europe, the US, China, when those vaccines are shown to be effective, we simply won't know whether they work equally in Africa. We have to be part and parcel of those studies. If not, we will be running. The rest of the world will have a vaccine, and we don't know if that vaccine works here or not. I would hate for us to be in that situation. And it's sad that these two doctors in France make scurrilous statements, unwarranted nonsense about that vaccines shouldn't be studied in Africa. They really have no grounds for that, and the Director General of the World Health Organization took them to task for that. The reality is, we know this of HIV, we know this for all diseases. If we do not get into the front door on the research, we have to join the back of the queue when these things work. And we don't want to be in that situation. We have to be part and parcel of these studies.
Thanks, Slim. That's very enlightening and informative. Listen, we've only got, I think, 3 minutes left, and I know you also are very busy. I would want to, on my list was to talk about personal protective equipment, but perhaps we can do that another time, because we know that we have a dire shortage. Although I did hear yesterday, I don't know if it's been publicized, whether I should mention it, but that the Solidarity Fund has spent 1 billion rand procuring personal protective equipment. I hope that it gets here fast. I did want to talk about the challenge between the understanding that you have kind of demonstrated and the practice on the ground, and the importance of our healthcare workers. I mean, we've been seeing in Britain a complete mess of a response, but the social solidarity between the ordinary population and the healthcare workers. You're probably not allowed to comment on why it is that we lock up 2 of our doctors in Limpopo, the MEC there. I hope that she gets the same treatment as the Minister for Communications from the President, because she should be censured, because the last thing we need to be at the moment is sending that signal to the people who are going to be on the front line in the next few months. Is there anything? We've got 2 minutes left. It's interesting. You shouldn't convey this to the minister. You shouldn't base anything on it. Your randomized control trials would pay no attention to it, but 79% of people we polled on this said that they would support the extension of the lockdown, which I think is very interesting, but it would suggest that people understand what we're doing here. Although I think you'd probably get a different result if you asked people living in an informal settlement, or people who didn't have water, who didn't have food, and so on. Any final comments, Professor Abdool Karim? Thank you very much. But anything you'd like to say in the remaining 90 seconds? Sure,
I'm very happy to. I mean, we know the trauma that this lockdown is causing. Many people who are self-employed are really dealing with the brunt of this problem, and so we have to do it. And we have to make those decisions very carefully. We have to base them on the best evidence we have. We're doing everything in our power to do that. But I want to end off with a note that, in fact, over these last few weeks, as I've watched Donald Trump and the mess that's going on in the US, Boris Johnson and the mess that's going on in the UK, I'm truly proud of South Africa. I'm proud to be South African in the way we have responded. We are a shining light in many instances. Everybody looks to what we have done, and I can see how proactive and how much we got ahead of this disease. I look at the way in which our ministers, our president, our civil society leaders, have all gotten behind this initiative. We have to beat this. And so I stand looking at all of this, and I feel proud of what we have achieved. And I want to end off with that we know those at the front line, our healthcare workers, they deserve every praise that we have. Keep it up. Thank you.
Thank you, Professor, and please pass our thanks to yourself and to many others I talk to regularly who I know are working 18 hours a day trying to puzzle this huge challenge out. It's enormously valued. It can be very lonely, but it's greatly valued. We have to beat this thing. There's too much at stake. We can't afford another HIV scale crisis for South Africa. So thank you very much. Thank you for all the people who've been part of this. I've been watching the numbers. We were up at 1,300 at one point. I don't know if that's good on webinars or bad. Thank you, Maverick Insiders. Thank you, ABSA, who have sponsored this and made it possible. And let's all pull our weight and hopefully dodge the bullet by our combined efforts. Thank you, Slim. Cheers. I'm signing out. Thank you. Bye.
Bye.